Hi, my name is Dr. Ahmed Elghawy, and today we're going to discuss a case of athletic rheumatism. This is a 20-year-old female who sought her medical care at the Cleveland Clinic Arthritis and Musculoskeletal Center for intermittent low back pain for the last 18 months. Now, she is a former high school gymnast with a previous medical history of spondylolysis at age 16 from repetitive lumbar hyperextension injuries sustained during her floor routines. This was originally treated conservatively with complete resolution of her symptoms. Though she started having similar symptoms about 18 months ago, this time without any hyperextension injury. She described it as intermittent, achy, worse in the morning, improving throughout the day, and with over-the-counter naproxen that she would take twice a day. She managed this conservatively, thinking that this was an exacerbation of her previous spondylolysis, limiting any aggravating activities, and was referred to physical therapy for rehabilitation. She was unable to tolerate therapy at first. The patient slowly started to become more sedentary for fear of exacerbating her low back pain. Since then, she admits to a 40-pound weight gain due to her inactivity, and so she presented here for further evaluation. Her physical exam was significant for tenderness of palpation along the bilateral sacroiliac joints and right piriformis, without any tenderness along the lumbar spine. She had a positive Faber's test bilaterally, as well as a positive Schober's test of 4 centimeters. Her laboratory findings were significant for a positive HLA-B27 and a normal sedimentation rate in C-reactive protein. Radiographs of the sacroiliac joint demonstrated sclerosis along the iliac margin of the SI joints, and the MRI of the pelvis demonstrated evidence of active sacroiliitis. The patient was diagnosed with axial spondyloarthritis and was started on adalimumab 40 milligrams subcutaneously every 2 weeks. Upon reevaluation at 8 and 12 weeks, the patient's low back pain had resolved, and she was performing her activities of daily living without any pain or loss of function. The takeaway here is to consider that even in young athletes with previous history of mechanical low back pain, inflammatory causes should be sought out in specific demographics where conservative management has not helped. This low back pain was different in quality and onset, which should prompt further evaluation for other causes. Now, athletes are really resilient and immune to a lot of things, but consider autoimmune conditions in the right clinical context.